Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Danya AlDahan, anterior segment consultant and anterior segment department at KKISH. We will be talking about keratoplasty indications and complications today. So this is the outline of our speak today. We will have a concise overlook over types of keratoplasty, the evolution of keratoplasty, some of the most common indications, and the most encountered complications. So as you can see here, the cornea is the transparent and avascular structure of the eye, which constitutes the anterior-most part of the eyeball. It consists of 6 different anatomical layers. The anterior-most is the epithelium, which is consisting of squamous cells, wing cells, and basal cells. The second layer is Bowman's membrane, which has regenerative properties. The stroma constitutes the major part of the cornea, and it contains keratocytes and collagen lamellae that are densely distributed in the anterior part as compared to the posterior part of the stroma. Those layers almost 10 to 15 micron in thickness, and it remains strongly adherent to the overlying stromal fibers. The innermost 2 layers are unable to regenerate, which are the descendant membrane, which provide a base for the endothelial cells that have a key role in maintaining corneal transparency. So corneal transplant or grafting is an operation in which abnormal corneal host tissue is replaced by healthy donor cornea. There has been a major shift in corneal surgery from penetrating keratoplasty to layer-specific corneal grafts. The preoperative evaluation includes not only a sophisticated general medical history, but also in addition, it needs to have an emphasis on the specific layer of the cornea involved with the disease. And each patient should be assessed in a very meticulous way, looking for risk factors and feasibility of each type of procedure. But still, penetrating keratoplasty remains an important procedure for the treatment of combined stromal endothelial disease and severe corneal scarring. Here you can see a simplified timeline for the evolution. In 1813, Hemley first mentioned the concept of corneal transplantation. But actually, von Hippel performed the first transplant in 1886 by replacing a human diseased cornea with rabbit cornea. But first, the first successful BKV was done by Zerm in 1906, where the graft remained clear for 18 months. Then a few years later, Fuchs did the first lamellar keratoplasty, which was not accepted well because of poor outcomes in terms of visual quality. Later, in 1948, the last technique of anterior lamellar keratoplasty was brought back. The first posterior lamellar keratoplasty procedure was described in 1950 by Baraker. Then further improvement in endothelial keratoplasty was done by using an automated microkeratome to perform the DASIC procedure, which was introduced in 2006. Subsequently, DEMIC, which is descendant membrane endothelial keratoplasty, was described by Millis in the same year. Corneal transplantation is broadly classified as full thickness, which is called penetrating keratoplasty, and partial thickness keratoplasty that can be anterior or posterior lamellar keratoplasty. Penetrating keratoplasty grants the ability to treat disease in the epithelial, stromal, and endothelial layer, as full thickness graft also eliminates optical interface related visual problems that may exist with lamellar transplants because of stroma to stroma interface hazes and opacifications. Corneal transplantation is most commonly performed and the most successful allogenic transplant worldwide. However, postoperative recovery time is relatively long, and it carries a significant risk of complications. So the technique of selective replacement of disease part has many advantages in terms of less intraoperative complications, maintaining globe integrity, and post-operative complications. There are various anatomical and clinical parameters that need to be evaluated before planning the type of corneal transplantation. And a stepwise approach may be utilized. And you can see here a flow chart describing the way that one can use to evaluate a patient prior to proceeding with keratoplasty. So if you have a full thickness opacity with poor endothelium, with clear lens, you can just go for penetrating keratoplasty. If it is accompanied by cataract, then you can do a triple procedure. In cases of anterior stromal opacity with good endothelium, depending on the depth of the opacity, where one can plan either superficial anterior lamellar keratoplasty. And this procedure is actually not frequently done nowadays with the use of PTK and laser machines that can treat opacities up to 50 or even more microns of the anterior cornea, or deep anterior lamellar keratoplasty, which is the most commonly performed anterior lamellar keratoplasty nowadays. And if you have corneal decompensation with poor endothelium, without anterior stromal scarring, then you can aim for endothelial keratoplasty in forms of DASIC and DIMIC. Corneal transplantation can be also classified on the basis of indication of which it is being done, into optical, which is the most common indication nowadays, and it aims to improve vision in cases like corneal scarring and corneal ectasia, or tectonic, which aims to preserve corneal integrity in cases of large corneal perforations, or therapeutic that aim to remove the infected corneal tissue that is unresponsive to treatment. And the final indication, which is very rare, is the cosmetic indication. In this part, we will have a look on the general indications for each keratoplasty type. Then we will go through some of the tables and figures from the 2019 IBank statistical report. So PKB is done for full thickness opacities such as healed keratitis or post-traumatic scars, some corneal dystrophies with endothelial involvement and corneal decompensation or anterior stromal scarring. It is still done for patients with keratectasia and keratoconus, especially if the patient is post-hydrobes or with descendant membrane large breakage. Anterior lamellar keratoplasty, as we spoke before, we have the deep anterior lamellar keratoplasty that is most commonly performed now, and it aims to remove and replace total or near total corneal stroma while preserving host healthy endothelium. There are many techniques for performing DALK, of which most famous is the manual dissection, where you can just go for direct open dissection, or dissection with hydrodelamination, where you hydrate the stroma so it will swell and made it easy to be dissected and more safer to the descendant membrane. Also, there is the closed dissection technique that uses a spatula and called the Mills technique to dissect between the stroma and the descendant closely, and then do the trephination afterwards. And there is also the dissection with Anwar's big bubble technique, where you can inject air between the stroma and descendant and then dissect the stroma. So the indications of DALK are keratectasia and anterior stromal scarring or opacification, as we mentioned before. Superficial anterior lamellar keratoplasty is not frequently done nowadays, but in general, it is used for opacities of the anterior stroma involving 30 to 40 microns. Posterior lamellar keratoplasties, the most famous posterior lamellar keratoplasties are basic endemic. It is used to replace the endothelium and treat the conditions in which only the endothelium is diseased and where the rest of the cornea is not affected, like in cases of Fuchs endothelial corneal dystrophy, aphakic and pseudophakic bullous keratopathy, and posterior polymorphous corneal dystrophy and other dystrophies of the endothelium. Also in cases of viral endothelial dysfunction and sometimes post-failed corneal grafts. If you have a failed PKB that was optically functioning well, then you can perform DASIK instead of repeating the PK. So let's have a look now on the 2019 eye banking statistical report of the Eye Bank Association of America. Here you can see a table of the utilization of the tissue supplied by the US eye banks, where you can see on the left-hand table, it includes all the tissue supplied by the eye bank nationally in the US. You can appreciate here that penetrating keratoplasty tends to decrease over the last 5 years, while the anterior lamellar keratoplasty stays stable in number, and endothelial keratoplasty significantly increased during the previous 5 years. Here in the left-hand figure, you can see the relative frequency of PK that is represented by the blue line, EK that is represented by the red line, and anterior lamellar keratoplasty that's represented by the green line that was performed in the US over the last 15 years. And you can appreciate clearly that in 2012, the endothelial keratoplasty procedure exceeded the penetrating keratoplasty procedure. This is a table showing the specific indications for penetrating keratoplasty in 2019. You can see that in the US, repeated corneal transplantation was the most common indication for penetrating keratoplasty, followed by ectasia and thinning. And internationally, the most common reported indication for PK is still ectasia, followed by repeated transplantation. This second table shows the specific indications for anterior lamellar keratoplasty in the US and internationally. Here you can see that the most common reported indication for LKB in both US and internationally is ectasia, followed by corneal degeneration and dystrophies. And here are the specific indications for endothelial keratoplasty in the US and internationally. In the US, the most common indication for endothelial keratoplasty was Fuchs dystrophy. As we mentioned before, pseudophakic and aphakic bullous keratopathy remains the most common indication outside the US. This figure shows the type of keratoplasty performed for each indication. So the blue color represents the number of the penetrating keratoplasty performed. The red color represents the endothelial keratoplasties, and the green color represents the deep anterior lamellar keratoplasty. You can see in the left-hand figure that in the US, the most common specific indication reported for keratoplasty at all was, as we mentioned before, Fuchs dystrophy. And actually 95% of those patients were treated with endothelial keratoplasty, and only 4% treated with PK. Keratoconus and other ectasia were the sixth most common specific indication for transplant in 2019 inside the US, and there was 89% of them had PKB for ectasia, and only 11% had anterior lamellar keratoplasty procedure. So you can see also on the right-hand figure that PK was done more frequently for patients with keratoconus worldwide. It is believed that the technical difficulty of lamellar keratoplasty continue to hold this procedure from trending worldwide for treatment of keratectasia. Now, let's move to the complications. Actually, complications of all types of keratoplasties are very long list, but we will only concentrate on the most common complications encountered. As we have seen before from the reports that until recently, PK has been the most common surgical approach for treatment of keratectasia and corneal scarring, but the newer procedures are really encouraged as they maintain structural integrity and avoid complications associated with open globe surgery. So although keratoplasty success approaches 90% in uncomplicated cases, only 65% of high-risk corneas are clear at 3 years, as have been reported in the literature. However, with a complete understanding of possible complications and frequent post-operative care, and this should be discussed thoroughly in the clinic with the patient, as a PK or a keratoplasty necessitate lifelong ophthalmic care and frequent visits to the ophthalmologist. This can minimize the problems and maximize the success. PKB complications can be divided into intraoperative and post-operative complications, and post-operative complications can be either early or late. Here we can see a list for the intraoperative complications. Those complications can be either related to the trephination, where you have an improper trephination size. A very small size will lead to a diminished optical quality of the graft and increase in astigmatism, while a larger sized trephination will lead to very large graft that is approaching the limbus and increasing the risk of vascularization and graft rejection. Also, if you have an eccentric trephination, will lead to a decentered graft that will also minimize the optical quality of the graft. Another complication is when you damage the donor button using the trephination, or when the host trephination is incomplete, which may lead to retained host descendant membrane, which might affect the endothelial cell integrity post-operatively. Another complication is damage to the intraocular structures like the iris or the lens, either by the trephination itself or by intraoperative manipulation, since this procedure is open sky procedure. Also positive pressure that might be as a result of either high intraocular pressure preoperatively, or some cases of soft globe, or in cases of younger host age, like in pediatric age. This might lead to iris incarceration in the wound during suturing, and also expulsive choroidal hemorrhage. So here are some of the early post-operative complications. Persistent epithelial defects. Actually, epithelial defects after PK should heal within 14 days. After this time, irreversible scarring and ulceration may occur. So if you have a delayed epithelial healing, ocular surface diseases like dry eye or exposure, trichiasis should be ruled out and treated. Options for treatment are lubrication. You can also use serum BSS or batching and therapeutic contact lenses. And when those preservative measures fail to treat an epithelial defect, then one can go for more invasive procedures like amniotic membrane transplantation and tarsorrhaphy. Primary corneal failure post-op is estimated to be up to 10% in the literature. It is diagnosed when a graft is edematous from the first post-operative day and remains so without inflammatory signs. And usually a deficiency of the donor epithelium is presumed. It can be also related to poor surgical procedure or also due to prolonged preservation time. Most surgeons will allow at least 1 to 2 months for spontaneous resolution before considering regraft for those cases. High IOP in the early post-operative period can be due to retained viscoelastic material. And if that is the case, then most probably the patient will need a release of the pressure by paracentesis and then placing him on topical or even oral aqueous suppressants. And an elevated pressure with shallow anterior chamber may indicate the presence of pupillary block, choroidal hemorrhage, or aqueous misdirection. I would like to stress on measuring IOP in the early post-operative period, as high IOP spikes can compromise visual prognosis by affecting the corneal endothelium as well as the optic nerve that might lead to poor visual prognosis. Endophthalmitis actually can arise from intraoperative contamination and also from donor button contamination, also from post-operative invasion of pathogen. The incidence of post-PK endophthalmitis was reported to be between 0.2% to 0.4%, which is higher than the overall risk in intraocular surgeries. It is well correlated with prolonged storage time of the donor button. However, the correlation with the positive donor rim culture is less clear, especially in cases of fungal infections. Early suture-related complications post-PK may present as wound leak, and when that leak is minimal and not causing AC shallowing, or when the only suture track is leaking, then one can observe it using patching and contact lenses for a few days. But if the leak was perfused and leading to shallowing of the AC or flattening of the AC, then this will need an immediate surgical intervention in terms of wound revision and resuturing. We will talk here about 3 late post-operative complications of PK, which are the most common and most serious complications. First is the graft rejection, which is the most common complication and the most common cause for graft failure. Studies reported an incidence of 8 to 37% of graft rejection episodes. This means that almost 1/3 of all PDs will undergo at least one time rejection episode, of which 7% will eventually lead to graft failure. Risk factors include corneal vascularization, especially if it is deep and occupying more than 2 quadrants of the cornea. Previous corneal or previous graft failure that will give almost 4 folds of probable failure in the second and subsequent grafting. Also, pre-existing local or systemic diseases and young host age. It can actually affect all layers of the cornea. So we might have epithelial, stromal, or endothelial rejection. Endothelial rejection is the most common and the most serious form. The signs are limbal injection in the early phase, sometimes with some AC cells, and then later it might progress into endothelial KPs and lines that are known as Hodadist line. Then might progress to corneal stromal and epithelial edema. The patients will have symptoms that are related to the inflammation and corneal edema, which are photophobia, redness, irritation, and blurry vision. The treatment should be prompt as soon as it is recognized, with very frequent, usually Q1 hour steroid drops in form of 1% prednisolone. Those with high risk or non-compliant can benefit from periocular or systemic, either oral or intravenous steroids. The second late post-operative complication that I'm going to talk about is the corneal astigmatism. Actually, nowadays, graft clarity achieved after transplantation is only one measure for keratoplasty success. But to the recipient, clear vision and good function is the most important thing. And refractive errors after keratoplasty significantly affect vision, especially when it is resulted from large astigmatic error, which are more problematic and difficult to manage. Astigmatism after PK averages between 4 to 6 diopters. The contributing factors are graft sizing and centration. That's why the trephination is very important. And also the trephination method. So the vacuum trephine are known to decrease the post-operative astigmatism compared to manual trephination. The host pathology also plays an important role. So after keratoectasia, like keratoconus and PMD, you expect a more of astigmatism post-op, and it might be irregular as well. Also, the graft host wound disparity and the suture tension and the irregular wound healing. So astigmatic correction actually starts from the early post-operative period when the physician elects to remove the sutures in a topo-guided manner. Then after the removal or the complete removal of the sutures, one can tackle this problem using either laser refractive surgery or astigmatic keratectomy or a lens-based surgery. The third common complication is the suture-related complications. As we know, sutures tend to be retained post-BKB for a quite long time, sometimes a year or even more. Suture loosening or breakage can happen anytime post-BKB, and any loose suture or broken suture must be removed immediately, because it's only going to invite infection and vascularization. If it is very early, within the first 6 months, then it's better to replace the suture. And if it is late, more than 6 months, and you can visualize a good graft host healing, then the suture can be removed. Also, infectious infiltrates post-BKB is a very problematic complication, and it happens because of the presence of foreign body inside the eye, which are the sutures, and also the immunocompromised status of the cornea because of the chronic use of corticosteroids. One study published from Kekish found an incidence of MK over graft around 12%, with streptococcal species were the most common isolates. Infections over graft need to be treated aggressively with corneal stains and cultures and prompt administration of frequent fortified antibiotic with very close monitoring of the patient. Hepatic keratitis also need to be ruled out in cases of infectious keratitis because those patients who suffer from herpes simplex preoperatively have approximately 25% chance to experience recurrence in the first year post-BKB. Another suture-related complication is suture vascularization. This actually needs a very prolonged time to be treated with either topical medications like immunosuppressants and steroids, and also subconjunctival injections. One can also do BDT or vessel cauterization in the OR if it needs to. Now let's talk about lamellar keratoplasty complications. So anterior lamellar keratoplasty have many advantages over PK, as it necessitates less strict requirements for the donor material, where you don't need an excellent endothelial cell count, you just need a clear stroma, and also it have a reduced risk of entry into the anterior chamber, so you will avoid all the complications associated with open sky surgical procedures, and also have less incidence of endophthalmitis and post-operative glaucoma. It also have a shorter wound healing time and a shorter visual rehabilitation, where you can remove the sutures relatively earlier than in PKB. It also reduces the incidence of allograft rejection, so endothelial rejection cannot happen in lamellar keratoplasty. It also decreases the need for topical steroids, and it has stronger tectonic integrity for the cornea. You will have an improved long-term endothelial cell viability in cases if you need another or further intraocular procedure. Also, it have a better prognosis for those who are less compliant patients. The most frequently encountered intraoperative complication for DALK is perforation of the cement membrane. Tears or perforations occur approximately in 10 to 30% of cases, as have been reported in the literature. You can use viscoelastic dissection or hydrodissection that will offer protection against perforation. So if a perforation occurs, management depends on the time and the size of the injury to the descendant membrane. And if the tear occurs while the stroma still covers the descendant membrane, it can be self-sealed, especially if it is small and in a superior location where it can be sealed with air bubble in the AC. If you have such a perforation in the descendant membrane, this might lead to a pseudo-double anterior chamber post-operatively, where a fluid escapes into the interface between the descendant and the stroma, or from retained viscoelastic material. When this happens, air injection into the AC help in the resolution. However, the air might affect the endothelial cell count, and it might elevate the IOP and may cause cataract. Another complication post-LKB that is special to LKB is ossification of the interface. This can be prevented by meticulous irrigation and cleaning of the debris of the bed from the bed of the host. and can be minimized with clear and regular stromal dissection. Also, LKB is not free of graft rejection, but the incidence is much lower than in BKB, where you have almost 5 to 8% of graft rejection episodes. And the presentation is quite different from PKB. It comes in form of only epithelial or stromal rejection, and usually it responds well to topical steroids. It is characterized by significant haze and deep vascularization that can lead to corneal opacification in the interface. Uritz-Zavalia syndrome, which is a rare complication for LKB. It is a fixed dilated pupil, secondary to iris ischemia. In cases where tamponade fails to manage, So those are the special complications for LKB. Of course, LKB also carries all the complications associated with PK in terms of suture-related complications, post-operative infections, and so on. Now let's move to the posterior lamellar keratoplasty. The advantages of posterior lamellar keratoplasty carries the advantages of not placing as many sutures in the ocular surface, so less incidence of corneal astigmatism and other suture-related complications, and more rapid visual rehabilitation and less concern of ocular surface diseases. So here are the basic complications that are divided into intraoperative and postoperative. The intraoperative complications are generally related to poor microkeratome dissection. Sometimes you have a perforation of the donor tissue where you can no longer use it. Also related to poor centration of the donor tissue in the back of the cornea because you cannot manipulate those grafts. So only tapping or massaging the cornea where you can center your graft. So it carries some intraoperative difficulty. Sometimes the donor tissue can be disoriented where the endothelial side can be stuck into the stromal side. Also, some surgeons face difficulty in incomplete dysmatorexis if any tags are left behind or a scarring was there in the cornea, so the dysmatorexis is incomplete. This will affect the attachment of the lenticule. Also, hyphema can happen intraoperatively, especially from performing surgical PI. As for the post-operative complications, donor dislocation is not uncommon. Actually, it's one of the most common complications post-endothelial keratoplasty. And it varies from 4% with experienced surgeons up to 35% with less experienced surgeons. Dislocation of the donor graft occurs primarily within the first 24 hours. And a major contributor factor to the dislocation is hypotony, where the IUB is less than 5. Or we can say also any fluctuation in the IUB in the immediate post-operative period will contribute to the dislocation as well. That's why we instruct the patient to avoid rubbing of the eye, and sometimes we even avoid measuring the IUB in the day following the surgery, just to maintain the globe integrity and not to have any IUB fluctuation. After the 24 hours, any trauma to the eye, like eye rubbing, or any trauma to the eye can cause the donor disc to be dislocated later on. If this happens, the dislocation is usually managed by air injection into the AC to attempt to reattach the donor button. Pupillary block as well is one of the complications after DASIC. If the release of the intraoperative air was inadequate or the patient leans forward, a pupillary block may occur. Sometimes the air bubble migrate behind the iris, and this will close the angle and causes a shoot of the IOP. And this can exacerbate an underlying glaucoma and also affect the endothelial cell integrity. Inferior iridectomy sometimes performed in DASIC patients to prevent this complication. Another complication is interface opacity. It may occur because of retention of fibers or very aggressive descent stripping. Also, incomplete removal of the descent membrane may cause interface obfuscation. Also, a retained viscoelastic material or fluid in the interface may lead to these obfuscations. Some surgeons elect to do venting incision from the anterior cornea to remove all the fluid in the interface and avoid this. Corneal rejection and failure following DASIC surgery may be lower than those of PK as a result of preservation of the anterior corneal surface. Also due to the absence of corneal sutures and overall less inflammation post-operatively, it is reported to be between 7 to 9%. Last but not least, let's talk about, sorry, it says DASIC here, but this is demic complications. So similar to DASIC, graft detachments is the most common complication in demic. The graft detachment after demic is usually different, where it tends to start with peripheral lifting of the graft edge. These lifted edges, as you can see in the pictures, can progress into complete graft dislocation. Initial reports of the graft dislocation that requires rebubbling or regrafting was actually very high, approaching 63% in some reports in 2009. But as surgeons gain more experience, fewer patients required repeated procedure, and the newer reports documented low rates as low as 9%. So the surgeon experience plays a major role in this complication post-demic. Also, there have been some advances in the surgical technique, and additionally, the use of SF6 gas appears to decrease this rate. Other complications include primary graft failure. Most probably, the primary failure is due to surgical trauma or damage to the donor tissue, because the demic tissue is very thin and very liable to injury with even minimal manipulation. Post-operative IOP spikes has lower rates despite longer airfill endemic procedure compared to DASIC. But it remains a concern because of the potentially blinding consequence of this complication. Thank you very much for listening, and if anybody have any question, you are welcome.